Tuesday morning. Unfortunately, a little cesspool disease in my house. Children passed on the sickness to me. It's just coming off the end of a cold here. It's not COVID, it's not tuberculosis, it's just a cold. But I'm going to stay back over here while I'm speaking to you today. And if you come up and chat with me, just make sure you wait till I get my mask on there. I don't want to spread all the cesspool germs down to you. But yeah, they are. They're little cesspool disease children. It's terrible. Anyway, we're going to pick up where we left off last day, looking at the urinary system. But before we do that, I do just want to highlight a couple of things. So first of all, your bell ringer, of course, is taking place next week. This should not be a surprise to you. There's an announcement posted on Blackboard about that, along with the schedule. So make sure that you have a look at that Blackboard, that bell ringer timetable, so you know when you're going to be attending lab. There's also an announcement there for folks who are observing Eve, because it falls on Tuesday or Wednesday this coming week. So make sure that you're looking at that announcement, and if you would like to sign up for a different time slot for regular bell ringer, then have a look there for that form. So make sure that you're looking at Blackboard, looking at those announcements, and making sure that you're showing up at the right time to write your bell ringer next week. This is a nice little breakdown here of the approximate number of questions that are going to be coming from each lab, just so you can kind of focus your time a little bit more. You probably figured out that the labs that have more terms associated with them are probably going to be more questions coming from those labs, and you would be right. So again, labs 2, 3, and 4 are the ones that are kind of the heaviest in terms of the number of different terms that you're responsible for, and so that's of course where you can see the majority of those questions coming, but just so that you're able to kind of focus your time a little bit more. There's also a practice bell ringer that's now available for you in the lab and tutorial folder on the main Blackboard page. So that went live today, this morning. So you can have a look there. Just like last semester, you can kind of go through and essentially practice your terms. But please, just like last semester, don't fall into the trap of only using that one practice bell ringer as your whole way of studying, because that's going to contain a couple of dozen different terms, and that's great, but you're responsible for all of the terms in the appendices. So when you're getting towards the end of your studying, absolutely use that practice bell ringer, set your timer, and then be able to kind of go through and recognize how long you actually have at each of those stations with each of those questions. But don't use that as your only method of studying, because of course it doesn't cover all of the terms that you're responsible for. All right. So that's happening next week, and then next week is our final couple of classes together, and then the week after that, of course, we have our final exam. So we only have 4 more classes left. This semester, we've done a lot more review than we typically have done in previous years. So this means that we're slightly behind where I'd like to be in terms of our content. So tomorrow, there's going to be a component of the reproductive system that I've recorded for you that you're then going to be able to watch at your leisure. This is the kind of the more straightforward components of the reproductive system, the tail end of the male reproductive component and the beginning of the female reproductive structures. And then in our last week together, we're going to be able to wrap up urinary, get a good start on the male reproductive system. In our final class together, I want to make sure that there's lots of time for review and for practice questions and for whatever questions you might have for me. So in order to get that time so that we can have some of that review time back, that's why I'm going to put that online for you tomorrow. You can look at it really anytime. You don't have to wait until next week. You can start that this week if you like, but that'll be available there for you until the end of the semester. So, quick. And then of course we'll talk about the final exam and all that next week once we're through this next component of the course. When you're studying for this, don't get into your own head. Just like last semester, it's only worth 10%, which is not nothing, but it's the smallest component of the course. So try to keep that in mind, keep that in perspective. The 2 term tests that you had were worth twice what the bell ringer is worth. The final exam is worth 3 times what the bell ringer is worth. So just to, again, as you're starting to ramp up your panic as you get into the later days of this week, just try to keep that into perspective that it is kind of the smallest component of the course. And if it doesn't go as well as what you would have liked, that's okay, because the final exam really has the capacity with a strong performance to really pull your mark out quite a bit. All right, So that's there. I'll put that up again tomorrow in case you didn't get a chance to kind of get that information, but we'll see that again tomorrow. And now what we're going to do is talk about our second to last unit and really narrowing down now on the functional component of the kidney, which is the nephron. This is where we left off last day, talking about this idea that the nephron is the basic functional unit of the kidney. All of those regulatory processes that we were talking about at the beginning of this unit, talking about things like fluid and electrolyte balance and acid-base balance and generating urine and all of these things, that's all going to be done by the kidney. And it's going to be done, by the nephron, and it's going to be done in 3 different steps. And so we're going to see that the generation of urine and all of this regulatory function comes down to essentially these 3 steps that are listed here. We're going to filter the blood first. We're going to throw out a whole bunch of stuff, useful things, waste products. Then we're going to pull back into the bloodstream the useful substances that we want to keep. And then we're going to be able to secrete more waste products. We're going to throw out more things that we want to end up in reverse. And those are the 3 major mechanisms by which all of the functionality of the kidney is going to be encompassed. We have about 1 million nephrons in each kidney. So overall, if you're born with 2 kidneys, you have about 2 million nephrons. You don't get any more. These are the 2 million nephrons that you have once you're born. And if you damage or destroy any of those nephrons, you don't get any new ones back. Obviously, your kidneys are bigger now than they were when you were an infant. So what accounts for the fact that your kidneys are larger as you're an adult than they were when you were an infant? Well, it's because of the individual nephrons growing in size. So we don't increase the number of nephrons that we have, we increase the size of each of the nephrons to allow for an increased filtration capacity and increased functional capacity. But if you damage any of the ones that we've got, you don't get any new ones. So this is why it's important to protect your nephrons and make sure that you're not exposing them to any toxic agents, which you'll get into in your pathophysiology course next year, all the different toxins and poisons that can damage your kidneys that you want to protect that from, and because you don't get any new ones. And so because there is this ability of nephrons, healthy nephrons, to grow in size, there is some capacity for you to be able to deal with damaged nephrons over the course of your life. If you're playing a contact sport, you get hit right in the kidney, you have trauma to that area of the kidney, you destroy some of the nephrons in that area, it is possible for other healthy nephrons to then increase a little bit in size to compensate for that loss. But there is going to be, of course, an upper limit. You can't do that forever, and so there will be an upper limit. You'll get into all of those details about how that works in terms of this kind of compensation for damage, in terms of toxicity and trauma in your pathophysiology. All right, keep your kidneys safe, keep your nephron safe. Now, the nephron is arguably one of the most complicated systems, or arguably one of the most complicated structures that we have in the body. There are whole courses just on nephrology, just looking at how the kidney works. So you can spend an entire semester just talking about the nephron and how it works. We're not going to do that. We're going to try to narrow this down to what do you need to know about how the kidneys work in about 2 hours. Okay, so that means that we're going to be doing a pretty superficial level investigation. I know later on tomorrow you're going to think, this is a superficial conversation? Holy smokes, there's a lot going on here. You're right, there is a lot going on here because it is one of the most complicated structures. But when it really comes down to what is the nephron and how is the nephron able to do all of this different functionality that we expect of it, there's only 2 parts. There's a blood vessel network and there's a tubular network. And it's the interaction between the blood in the blood vessel network and the fluid in the tubular components of the nephron that allows for all of this functionality. So if we can always kind of try to come back to this idea that really, when we're really deep down into these details later today and into tomorrow, really it's just 2 parts. Blood vessels and a tubular component that has fluid traveling through it. And if we can keep that in mind, and we can always kind of go back to that, then maybe it won't quite seem so daunting. Okay? So this network of blood vessels you can see drawn here. Obviously there's going to be some red ones indicating this is oxygenated blood, and then there's going to be some purple ones, and then some blue ones indicating that yes, there's some capillaries that are going to be going on here, but some other important blood vessels. There's a ball of capillaries that we'll talk about in a few minutes. Okay. And then of course there's this gold or yellow colored tubular component, which is going to be that second portion of the nephron. Last day we were looking at this blood supply into the kidney. We said that it starts in the renal artery, and there's a whole bunch of different branches, and eventually you get out to that periphery. We saw that image right when we ended last day's class, and it looked kind of fuzzy on the outside of the kidney, because that's where all of those thinnest, smallest diameter blood vessels are found, is all around the periphery of the kidney, and that's where we find these nephrons, is in the cortex of the kidney itself. So when we continue on from last day, looking at that blood supply, starting in the renal artery, then there were a whole bunch of branches that we didn't really care about their names, but branching out to the periphery, until we get to this afferent arteriole. What did we say about this afferent arteriole last day? What does afferent mean? Towards, exactly. I know some of you were still coming off of Dr. Stewart's test last week, so it may not have kind of all sunk in, but you're talking about afferent moving towards something. Well, if we're talking about moving towards and away from a structure, what is it that we're talking about? What is that point of reference? And it turns out that in the nephron, our point of reference is always going to be the glomerulus. So the glomerulus is going to be a complex kind of ball of capillaries. And it's going to be surrounded by the first portion of the capsular component of the nephron. And we'll talk more about that specific interaction between the glomerulus and the capsule in just a minute. But for now, we're just looking at blood supply. So this is our afferent arteriole bringing blood into this ball of capillaries. Now, what do you notice about how we've drawn this ball of capillaries? How is it different than other types of capillaries that we've drawn in the past? Yes, it's a ball. That's a bit of a strange thing, but there's another important difference here. Look at the color. How do we normally draw capillaries? Looks like it's just oxygenated blood. Normally when we draw capillaries, they look more like these down here, where there's a transition from red to blue. There's some kind of purple stage in between because we're having that gas exchange happen. But we don't see that here in the glomerulus. And that's because there's no gas exchange, or very, very little gas exchange, that's taking place in the glomerulus. That's not the purpose of this ball of capillaries, is not gas exchange. As we're going to see a little bit later on, the purpose of this glomerulus is for filtration of our blood. So keep that in mind as a big difference here in terms of this ball of capillaries as opposed to the typical capillaries that we talk about. So if this is our kind of point of reference, this glomerulus, we have the afferent arteriole that's bringing blood into the glomerulus. We're then probably going to have an efferent arteriole that's carrying blood away from the glomerulus, and that's exactly what we find. And so we see that labeled here. So efferent meaning away from, so we're carrying blood away from this glomerulus. This efferent arteriole now is going to branch into a much more typical type of capillary network that we are used to seeing, and these are called the peritubular capillaries. What does peri mean? Now everybody stop. Don't get too close. I know. Back over here. Around. It means around. So peri means around. So the peritubular capillaries is this network of capillaries that surrounds the tubular component of the nephron. And this is going to be the second major place where interaction is going to happen between the blood in these peritubular capillaries and the fluid that we're going to find in these renal tubules. Okay, so we've got this peritubular capillary. These are all peritubular capillaries all the way down. You can see all these branches that are coming off. And then, of course, the peritubular capillaries will merge together to form the interlobular venule, and then we'll be working our way back, our deoxygenated blood working its way back out of the kidney itself. And so then we can take a big step back. There's our interlobular vein, and then you can see all of the rest of these blood vessels draining deoxygenated blood away from the kidney. And what do you notice about all of these names all the way back to the renal vein? What do you notice about these ones? And how how do they compare to the arterial side? Hey, they're all the same. So they all have the same names. Okay, so this is sometimes helpful in trying to figure out which ones are which. They all have exactly the same names and they lie side by side in terms of their flow. Okay, so we're not going to worry too much about the names of these different blood vessels, at least for the lecture portion of this of the course. We are interested in what's happening in that nephron itself, and what's that blood flow doing in the nephron, and how is it going to be working, because that's really kind of that functional component there. All right, this then allows us to zoom in a little bit more closely. So we see, yes, that we've got this glomerulus, so that's our little zoomed in area right here, that kind of ball of capillaries right there. What's this blood vessel here? That's our afferent arteriole carrying blood towards the glomerulus. What's this blood vessel here? That's our efferent carrying blood away from the glomerulus. There are peritubular capillaries. And now if we zoom in right on this area that contains the glomerulus, we find this structure called the renal corpuscle. So the renal corpuscle is made up of two parts, that glomerulus that we just talked about a minute ago, that ball of capillaries, as well as the proximal portion of the tubular component of the nephron. And so this is going to be our glomerular capsule. Now you may have learned this as Bowman's capsule in the past, and again, Bowman was the physician who discovered this structure. But again, trying to get rid of people's names, and so now it's more properly called the glomerular capsule. If you really like Bowman and you really want to no, I want him to be recognized, fine, you can use this name on a bell ringer if you want, but a more proper term to use is the glomerular capsule. So this glomerular capsule then is a double-walled cup, and we'll talk about the structure of this cup in just a second, but it essentially is going to be wrapped around this ball of capillaries, this glomerulus, and capture any fluid that is going to be coming out of that glomerular ball. So just like any other capillaries that we would find in the body, all of those same forces that we talked about before, hydrostatic pressure, osmotic pressure, that movement of fluid in and out of the capillaries, that's all going to apply here as well. It's just that now, rather than the fluid leaving the capillary and entering into the interstitial space, any fluid that comes out and dissolved particles that come out of the glomerulus doesn't just move into the interstitial space, it gets captured in this little cup. It gets captured in this glomerular capsule and then sent further along into the rest of the tubular component of the nephron. So we're going to see how that works again in just a second. For now, we want to zoom in on this renal corpuscle. So again, just to kind of orient ourselves, this is our glomerulus at the center here, and then we have this capsule around the outside. So there's the glomerular capsule. As we said, it's made up of two different layers. It's a double-walled cup surrounding the glomerulus. There's the blood vessels there. As you can see, what blood vessel is this? Afferent arteriole coming in. We'll label this in just a second. There's the efferent arteriole going out. There's the glomerulus. And then surrounding that, we have this little space, because that's the space that the fluid is going to start to collect in. So as fluid is coming out of this glomerular ball of capillaries, it's going to be captured into this capsular space. It's not going to be allowed to just float away wherever it wants to go, because it's going to be contained inside this parietal layer of the capsule itself. The second layer, we said it's a double layer, two layers of this glomerular capsule. The first is the parietal layer around the outside. And then we have the deeper layer, which is actually on the surface of the glomerulus itself. So it's made up of all of these little cells that are called podocytes. Podo means, what does it mean? What does it mean? Foot. It means foot. So podocytes mean, or a podocyte is a cell that has all of these little quote-unquote feet that are going to be attached onto the surface of the glomerulus. In fact, you can't even see the surface of these capillaries, because all of these podocytes, these cells with all of these branching feet, are kind of wrapped around the outside surface, the superficial surface of the glomerulus itself. And so these two layers then, this visceral layer and this parietal layer that forms the cup itself, forms the glomerular capsule. In between those two types of cells, in between this simple squamous epithelial layer and these podocytes, is where you find our capsular space. And that's what's going to accept or receive or collect up any fluid that filters out of the glomerulus, and then send it further along down into the next portion of the tubule. So together then, this glomerular capsule with its two different layers and a space in between, along with this blood supply, this glomerular capillary net, is going to be called the renal corpuscle. So we talk about these two components, and as I said, this is the first time that we're going to see this interaction happen between the blood that's coming into the glomerulus and this fluid then that is going to be captured by the glomerular capsule and then sent further along into the tubule. So that's the renal corpuscle, and we're going to see this in a lot more detail. We're going to zoom in a little bit closer in just a few minutes when we start to talk about filtration. So that's our renal corpuscle. Just to give you a perspective of what this looks like in reality, this is a section through the superficial area of the kidney. So this is the cortex that you're seeing here. That's the surface of the kidney right along the top of this picture. All of these little balls that you see here, what are those? The glomeruli. So all of those glomeruli. Now we said that each glomerulus is going to be associated with one nephron. So that means that you can start to see how tightly packed these nephrons are, all side by side by side by side, all jammed into this space, because there's one glomerulus and all of its blood supply in and out and all of its tubular components. There's another glomerulus and its whole nephron, and then another one, and another one, and another one. And all of a sudden you start to see how we're able to jam 1 million of these nephrons into this relatively small space. We zoom in a little bit closer. This is in my top 5 favorite science photos of all time. This is so cool. What is this? It's on the slide. Giving you a hint. This is the glomerulus. Okay, so what they've done is they've peeled away the capsule, and they've just left that blood supply. So you can see this ball of capillaries. These are all the capillaries that you kind of all balled up into a sphere. What's this blood vessel here? That's our afferent arteriole coming in. And what's this blood vessel here? That's the efferent one carrying it away. Notice that the afferent and the efferent arteriole, okay, are 2 different diameters. So when we talk about 2 different diameters, which one's the bigger one? Afferent. The afferent arteriole is the one that's larger in diameter. We're going to see this a couple more times. This is very important that we recognize that the afferent arteriole is larger than the efferent. This means more blood volume is coming into the glomerulus than you are allowing to drain away through the efferent arteriole. So that's going to have an effect on the pressures that are being exerted inside the glomerulus itself. If you look at the renal corpuscle, we remember the renal corpuscle is made up of what? What's the renal corpuscle? There's 2 parts to the renal corpuscle. What is it? The glomerulus. So the glomerulus that you're seeing right here. So that's the first part of our renal corpuscle. The second part of the renal corpuscle is the capsule. And the capsule has 2 different layers that makes up that capsule. So if we look at the renal corpuscle, this shows us, I think, a little bit more nicely what this structure is. So you can see the ball of capillaries. There are all these false color pink podocytes wrapped around the outside of those capillaries. And then you can see this space. Right? This brown area around the outside, that's going to be our capsule. You can imagine that any fluid and dissolved particles that come out of the glomerulus is then going to be moving into that capsular space and is then going to be shunted further along into the next portion of the tubule. Okay, so this is our renal corpuscle, and we'll come back and see this image again a little bit later on when we talk about filtration specifically. All right, so that's the renal corpuscle, the first time that blood and filtrate, the fluid coming out of this glomerulus, are going to be able to have this interaction. Now we want to talk about the second part of the nephron. What's the first part of the nephron? The vessels, the blood supply, so all those afferent arteriole, glomerulus, efferent arteriole, peritubular capillary. Now we're going to look at the second component of the nephron, which is the tubular component, so the renal tubule. And that's everything that's drawn in this kind of gold or yellow color here. So we have our proximal convoluted tubule. Okay, let's look at these words. Proximal. What do we mean by proximal? Close to. Okay, what is it that we're close to? nephrons are marker posts all the time. The glomerulus or the renal corpuscle, right? So kind of that beginning structure is going to be whether we're moving towards it, afferent versus efferent, or whether we're close to it or far away from it. So because this is the very first portion, the very proximal portion of the tubule, it's the part of the tubule that's connected right onto the capsule, well, yeah, we're going to give it the name proximal because it's the closest region. What does convoluted mean? That's lectures are convoluted. Hey, talking, and I don't understand what's going on. What's convoluted mean? Confusing? Yeah, that's what I have. Yeah, so it's all kind of like twisted and turning and all kind of like twisted around. So convoluted means it has a complex pathway. And so you can see that here. It's all kind of twisting and turning. And it's got all these kind of all twisty around. That's what convoluted means. Okay, so proximal convoluted tubule is this first portion of the tubule. Then we straighten out a little bit, and from this convoluted organization, twisty-turny, into the nephron loop. Okay, you may have learned this as the loop Henle. Again, Henle, you don't care about that anymore. So now we changed the name, and it's now called the nephron loop. So this nephron loop is going to extend quite a ways down into the medulla of the kidney. Where was the medulla? The middle, so the center of the kidney. And so that nephron loop extends down, and then it makes a 180-degree hairpin turn, and then it reascends back up into the cortex. And it's going to work its way back up here until it's relatively close, once again, to that renal corpuscle. Once we reach then back up into the cortex, and we start this, once again, kind of twisty, turning pathway, we're going to change the name of this component once again to now call it the distal convoluted tubule. Convoluted because it's got kind of a twisty, turning, windy course. Okay? But distal, why distal? Because it's farther away from what? The glomerulus. But this kind of looks like it might actually be even like closer to the glomerulus. So why are we calling this the distal convoluted tubule then? Sorry? It's farther along the pathway. If you were to take that tubule and pull it out, stretch it all out in one big long line, you're now very, very far away from that capsule, right? The fluid that was captured by that capsule has traveled along through the proximal convoluted tubule, through the nephron loop, and now here into the distal convoluted tubule. It's traveled a long way from where it started, and so it is quite a bit distant from it, and so that's why we call it this distal convoluted tubule, even though once we kind of scrunch it all up into its three-dimensional configuration, it might look like it's positioned a little bit more closely to the glomerulus. But the fluid that's traveling through it has traveled a long way from its starting point back here in that glomerulus, and so that's why we call this the distal convoluted tubule. From there, the distal convoluted tubules are going to drain our newly formed urine into collecting ducts, and then eventually papillary ducts, and then we're going to be able to get that freshly formed urine draining into the drainage system through the kidney, starting with the minor calyces and the major calyces, and then eventually down into the bladder. We'll talk more about that once urine has been formed. All right, so that's the tubular component of the nephron. So again, I know it's starting to get a little bit like, what's happening here? There's a lot of different parts. Yeah, but there's only really two, blood vessels and tubules. And it's the interaction between the blood in the blood vessels and the fluid in the tubules that is going to allow for all of the functionality of the nephron itself. Now, nephrons can be organized into two different categories based on, a little bit on their shape, but mostly on where they are located. What's going to be our marker post for our point of reference in the structure of the nephron? What is it always? The glomerulus or that corpuscle, that renal corpuscle. So, when we look at the position of that renal corpuscle and that glomerulus, we see that about 80 to 85% of our nephrons are described as being cortical nephrons. What does cortical refer to? The cortex. So this means that the nephron, the majority of the structures of the nephron are going to exist in the cortex itself. So you've got that renal corpuscle that's going to be up towards the surface of the cortex. You've got the proximal convoluted tubule, the distal convoluted tubule. It's all up towards the superficial surface of that cortex, and only a little bit of the nephron loop descends down into the medulla. And so these are called these cortical nephrons, where that corpuscle is in that superficial or outer cortex. As I just mentioned, the nephron loops are relatively short. They do penetrate down into the medulla. That's our dividing line right here. As we saw last day, the lighter colored outer area is the cortex. The deeper, kind of richer, darker color is at the center. That's the medulla. And so we just see a little bit of that nephron loop extend down before it then makes its way back up into the cortex. Peritubular capillaries are all of these blood vessels that are surrounding all of these tubular components of the nephron, as you can see them here. Okay, great. So 80 to 85% of our nephrons are of this variety and are going to be doing the job that we're going to talk about in a couple of minutes of filtration and reabsorption and secretion, and being able to regulate all of those fluids and electrolytes in the body, but also generate our urine. The other type of nephron, that last kind of 15 to 20%, are called juxtamedullary nephrons. That's a good one, juxtamedullary, that's a fun one. So juxtapose, what does that mean? If you juxtapose two things, what are you doing? Lost a bit of a grammar lesson today, too, here, a vocabulary lesson. What are you doing if you juxtapose them? You kind of put them side by side. So if you're going to be juxtaposing two different ideas, you put the two ideas side by side and you say, okay, how do they compare? How are they similar? How are they different? Here, when we say juxtamedullary, we're saying that we're coming up right beside the medulla. So the renal corpuscle is still going to be found in the cortex, but it's much, much closer to the medulla than what we find for our cortical nephrons. So now you can see that cortex, and again, if we go back a slide here, you can see there's our renal corpuscle up towards the superficial surface. Now that corpuscle is deeper into the cortex, and we have a much, much longer nephron loop. So this much longer nephron loop then is going to require not only the peritubular capillary to be present, which it is, you can see the peritubular capillary all around it here, but also now this kind of extension of the peritubular capillary called the vasa recta. And so that's all of these blood vessels that you're seeing here, this vasa recta supply to keep this interaction between the fluid in the bloodstream and the fluid in our nephron loop able to interact. And when we look at why we have two different types, it turns out that we want to be able to have the capacity to regulate the concentration, if you want, of our urine. And this is going to be reliant on how much fluid you're taking in every day. The more you're drinking, well, the more you have to get rid of, right? So that we can maintain our nice normal homeostatic balance. As we said way back in September and kind of all the way along, everything you do or don't do to your body messes up homeostasis. So if you drink a lot of water because you think that's really healthy, yeah, that's great, but you only need a certain amount of water every day to have the right concentration of water and electrolytes. So now your kidneys have to get rid of all that extra water. So then you say, oh, yeah, well, I won't drink water then. And then the kidneys say, well, okay, but we need some water. We need enough water to be able to have the right concentration of water and dissolved substances. So now we're going to have to hold on to more water in the bloodstream and not put out so much into the urine. So we have this capacity to change the concentration of our urine, making it more concentrated, lower volume but more concentrated, or more dilute with a higher volume, depending on your fluid intake. And so it's these nephrons in this juxtamedullary position with these very, very long nephron loops that are going to help to regulate and generate either very dilute or very concentrated urine under the control of ADH. What does ADH do? What is ADH? Antidiuretic hormone. What does it do? Causes us to do what with water? Reabsorb, to hold on to more water and put less water out into the urine. And so this is where we're going to see once again this activity of antidiuretic hormone coming into play, of course, in the kidneys. All right, so let's take a look then really, the whole idea of the functionality of the nephron comes down to urine formation, and through urine formation, we can regulate all of these other fluids and electrolytes, like water, and hydrogen ions, and bicarbonate ions, and glucose, and sodium, and amino acids, all of these things that we need to be able to regulate the concentration of. We're going to be able to do that through the activity of the interaction between the blood in our blood vessels of the nephron and the fluid in the tubules. So this is just a different way of drawing the nephron. So this is our glomerulus that's right here. So you can see that would be an example of a ball of cells, or a ball of capillaries that they just stretched out. Then we have the capsule that's right around that there. And then we have, of course, the rest of the tubule that extends down. So that would encompass, of course, the proximal convoluted tubule, the nephron loop, the distal convoluted tubule. They just stretched it all out into one line to make it a little bit easier to look at. If you don't like looking at it this way, that's fine. If you would rather the kind of the more complicated regular pattern, that's fine. Look at that. It's the same idea that we're going to be talking about. When we look at urine formation, there are 3 steps, and we kind of alluded to some of these already. So there's going to be filtration, and this filtration is going to happen from the glomerulus. So there's going to be fluid and dissolved substances that leave the blood in the glomerulus, but rather than leaving the blood in the glomerulus and traveling into the interstitial space and then coming back in at the venous end of the capillary, that fluid is going to be captured by the capsule and be sent into the tubular components, and that's going to be the fluid as the filtrate that's flowing then through our tubule. So the first step is going to be glomerular filtration. Then we're going to see that we want to reabsorb all of the useful things that we want to keep back in the body. At the end of this pathway, whatever is left in the tubule is going to become what? Urine. So whatever fluid, whatever dissolved substances, whatever waste products, whatever potentially useful things stay in that fluid in the tubule at the very end of this pathway is going to eventually end up in the urine. So if there are substances like glucose or amino acids that we don't want to end up in the urine, that we don't want to throw away, we want to hold on to those, well then we have to reabsorb them back into the bloodstream. So we're going to pull those useful things from the filtrate that we just created in the first step. We're going to pull those useful things back into the bloodstream. The third step then is to say, okay, so in this first filtration step, we got rid of a bunch of things, including some waste products that we want to throw out, and we want to leave that out in the filtrate, and off it goes into the urine. Fantastic. But did we move the entire volume of blood out of the glomerulus and into the capsule? Did you take all of the liquid portion of the blood and move it out into the capsule? No, because what would you be left with then in the glomerulus? Yeah, like a whole bunch of just like dried up like red blood cells like flopping around like a fish out of water. Like it's not going to work, right? So no, you're not going to move all of the volume of blood out of the glomerulus during filtration. But if you don't move all of it, that means you probably still got some waste products in the bloodstream that you want to get out into the urine. So now we have to have a third step, which is called secretion, to be able to get rid of those last waste products, put that into our filtrate so that it can then become part of the urine as well. So these are the 3 steps then into which we organize urine formation. So we're going to start now by looking at filtration. Oh my gosh, what is this that you're seeing here? I know you don't have this in your notes, but you have it in a bunch of other places in your notes. What is this? Starlight law, capillary exchange, hooray! Filtration happening at the arterial end. What drives filtration at the arterial end of a capillary? Hydrostatic pressure. What drives reabsorption at the venous end of the capillary? Osmotic pressure. What's the only pressure that changes from one end to the other? Hydrostatic. All other pressures stay the same, right? Because you've got osmotic pressure that's drawing fluid back in at this end, but it's just overpowered by the amount of filtration that's happening. So think about this idea. Starling's law, you got that locked in your head now. We talked about it like 15 times. Well, twice, but we talked about it a lot, right? So keep that in your mind because the glomerulus is a capillary. And if the glomerulus is a capillary, that means that the same forces that were acting in a systemic capillary, hydrostatic pressure, osmotic pressure, in two different places, those are going to be the same pressures that are going to be active here as well. All we've done is take a systemic capillary like this, and we've taken all of this kind of mesh-like network of capillaries and scrunched them up into a ball. And rather than the fluid that is leaving by filtration, moving into the interstitial space, we're going to capture it. And we're going to send it into the tubular component of the nephron. The capsule will trap that fluid and send it further along the rest of the tubular components. But it's exactly the same process that we've talked about before. Those same pressures that we were talking about before are going to exist here. And it's actually even a little bit more simple because we really only talk about 3 of the 4 of them, because the 4th one doesn't really change ever, so we don't even bother talking about it. So we're going to look at really 3 of those same 4 pressures that we've already talked about a number of times. Is the name a little bit different? Yeah, because rather than talking about the interstitial hydrostatic pressure, for example, we're now going to talk about the capsular hydrostatic pressure because the fluid is trapped inside a capsule, but it's exactly the same thing. So again, don't get overwhelmed here. A lot of this is, we've already seen this, we're just making a bit of a tweak to it, but it's essentially the same process that we've already talked about. So because we're looking at filtration right now, our focus is now really on this arterial end. So remember what's going on at that arterial end in terms of the different pressures that are going to be involved and how fluid is going to be moving at this arterial end of the capillary, because that's really what glomerular filtration is all about. You'll notice that this name, filtration, is used in both cases. That's not an accident, because it's the same thing. The same thing is true in the systemic capillary as it is here in the glomerulus. Fluids and dissolved substances move through the glomerular membrane, right, as part of, and it's captured by the capsule. Where have we seen that before? The capillaries. This is the same thing. We move the fluid from the blood, from the capillaries, across that capillary wall and into the interstitial space. It's just that now, rather than the fluid moving into the interstitial space, it's moving into the glomerular capsule. We don't just let it flow off wherever it wants to go. It's going to be captured in that capsule and then sent further along the rest of the tubular component of the nephron. Just like we saw before, this is a non-selective process. The only thing that is going to determine whether a substance moves from the capillary into the capsular space is what? Size. Size is the only thing that determines it. Not whether something is useful, not whether something is a waste product or not. It's only size. So we're going to see that when filtration happens, as long as those substances are small enough, regardless of whether they're useful or not, they are going to be able to be filtered out of the glomerular blood and then captured by that Bowman's capsule or that glomerular capsule. Well, wait a minute. Why are we throwing out useful things? We're spending all this time throwing out a whole bunch of useful things like glucose, because that's pretty small, amino acids, they're pretty small, a whole bunch of water. Why are we throwing out useful things to then, in the second step, just hold back the useful things that we want to keep? That seems a little bit backwards. Why don't you just hold on to the things that you want and throw out the things that you don't? It turns out it's all about energy. It's much, much more energy efficient to do it this way because we're going to be able to harness concentration gradients to start moving things back and forth across our peritubular capillary wall. It's much more efficient to use concentration gradients, which don't require any energy, than it is to have to select for each individual thing that we want to keep or that we want to throw away. So keep this in mind, that this idea of non-selective means that size is the only thing that matters. As long as it's small enough, it can come out of that glomerulus and be captured into that capsular space, form part of that fluid, that filtrate that comes out. We'll worry about getting the useful things back later, okay? But for right now, we're just going to be pushing some of these smallest molecules and substances out of the glomerulus. Small particles, as we said, water, waste, so yes, we're going to get rid of them, but also useful things like nutrients and electrolytes pass out of the bloodstream, whereas those larger particles, as we've seen before, things like albumin, red blood cells, normally they should not be able to get across that glomerular capillary same as what we've seen before, right? We don't have red blood cells coming out of the capillaries. They had to stay in the capillaries, otherwise, well, you're bleeding, right? That's what's happening if you've got red blood cells coming out of your capillaries. That's internal bleeding. So we're obviously going to be keeping these larger components inside that bloodstream, just as we've always seen. And hey, look at that, it's blood pressure that we're talking about. That hydrostatic pressure is what's driving, for the most part, driving this movement of fluid from the glomerulus out into that capsular space. Okay. The filtrate then is the term that we use to talk about all the fluid and all of the small dissolved substances that have come out of the glomerulus and have been captured by that glomerular capsule. Okay. The fraction of that blood is about 16 to 20% or so. We said a few minutes ago, not all of the fluid volume of the blood can come out of the glomerulus, because if you moved all of the fluid volume out of the glomerulus and into the capsular space, you've got your red blood cells there like the fish on the ground, just kind of like flopping around, these red blood cells with no fluid to be able to move them through. So only between 16 and 20% of the overall volume of the blood actually comes out of the glomerulus and is captured by that capsular space and becomes the filtrate itself. But now that we've generated some filtrate, it's going to be the interaction between the blood that is still in the capillaries and this fluid that we've just generated that is going to allow us to have all of that regulation of different fluids and electrolytes and generate urine and all of these kinds of things. Whatever remains in the tubular component is eventually going to become urine. So whatever ends up at the end of this whole pathway in this filtrate will become urine. We're going to see we change the name at the very distal end of the tubule. We're going to stop calling it filtrate once we can't make any more changes to it, and we're going to start calling it urine. Okay, so the filtrate is what we're going to be working on, is this fluid that we're kind of crafting and we're creating all the way along the length of the nephron until eventually we've created urine. And that's then what we're going to be dumping to the outside of the body.
So just to clarify, this 16 and 20%, that's all happening kind of in a continuous motion as opposed to like kind of like spits in, like squirts out of time.
For sure. So this is happening continuously, and we'll talk a little bit more about our glomerular filtration rate in just a second and how quickly this is happening and how much this is happening. But yes, this is not fits and starts or kind of spurts like it was with chyme in our stomach or small intestine. This is a constant flow of fluid that is always going to be leaving the glomerulus, and then we'll see in our next stage a constant reabsorption that's going to be happening as well. It's not like we're dumping 2 liters of fluid through this through this filtration step, and then pulling it all back later. It's just a constant flow, right? So,
And at the same time, as you do that exchange, obviously that's seconds of coming back.
Exactly.
Therefore, there's not really like
an overall change. Exactly. There's not going to be an overall change in your fluid volume, in your blood volume, because you're going to be filtering out 16 to 20%, and then as we'll see, you're going to pull back in about 99% of that back into the bloodstream. So it's going to be, again, this kind of constant flow of fluid out and then back in once again, hopefully leaving the last little bit of fluid out in this tubule, which is going to become the urine. Good question. All right, so let's take a look then at this glomerular filtration and how we can make sure that it's going to be happening well enough. So obviously a large surface area. The more surface area you have, the more opportunity there's going to be for filtration to take place. This is why we're able to have these glomeruli organized the way that they are. You could take all of those capillaries in this glomerulus and flatten them out, spread them all out into kind of a, like lay it out on the floor, and that would take up a pretty big surface area, right? But then you'd have less of them able to be jammed into your kidneys. So instead of just laying them out all kind of flat like we draw our systemic capillaries, they're scrunched up into a nice little ball. So it takes up less overall space, but you still have a very large surface area to allow for that filtration to occur. Next, of course, as with any kind of filtration, you're going to want a thin, very, very permeable membrane so that you can allow for those small structures and substances to be able to leave the capillary very, very easily and then be captured as part of that filtrate. So we're going to talk more about that filtration membrane itself in just a second. And again, this has to be a balance. has to be very, very permeable for small things, but not permeable to large things, because if it was super duper permeable to anything, well then red blood cells would come out and proteins would come out. We don't want that. We want to keep all those larger structures in the bloodstream. And so yes, we want it to be very permeable for small things, okay, but still be able to maintain a pretty strong integrity for resisting the movement of blood cells and protein. And then we want to have a relatively high glomerular blood pressure. We want there to be a relatively high hydrostatic pressure inside the glomerular capillaries, because what is that hydrostatic pressure doing? That's what's driving the filtration, exactly right. That's what's pushing the fluid and dissolved particles out of the glomerulus, is this hydrostatic pressure. And so it turns out that the hydrostatic pressure that we have in our systemic capillaries, what value did we say that was approximately? About 35 millimeters of mercury worth of pressure. That was enough in our systemic capillaries to be able to get filtration to happen fine enough. Here, we want that pressure to be a little bit higher. So we've got this normal 35 millimeters of mercury because the heart's contracting and that's our hydrostatic pressure in these capillaries. Now we want to enhance that a little bit more. We want to bump that pressure up a little bit more to really make sure that filtration is happening very, very efficiently. And so now we come back to this idea of the different diameters between the afferent and the efferent arteriole. What we say was the difference between those diameters. The afferent is larger. The afferent has a large diameter, which means more blood volume is able to move into the glomerulus than you're allowing out at the other end. And that's then going to mean that you have a higher pressure. You're forcing more blood in at one end than you're allowing out the other. So that means that the pressure inside that glomerulus is going to be even higher than what we typically find in our systemic capillaries. And that's really then going to drive this movement of fluid out of the glomerulus and into the capsular space. So here we have our filtration membranes. Our beautiful little drawing that we see from the textbook. There's the glomerulus wrapped in those cells. What do we call those cells? Podocytes. They've got those feet, these branches that are all kind of wrapped around the surface of those glomeruli. And then you've got our capsular space with, of course, the capsule to trap all of that fluid that's going to come out. So let's zoom in then. Oh, look at that. You see it? Do it again, right? Zooming right in on that filtration membrane. Okay, and this is what we see. So we've got a couple of different layers here. The more layers you have, the more opportunity there is to resist the movement of substances across that wall. We want it to be permeable to small things, but pretty impermeable to larger structures like red blood cells and albumin. So the first layer, the inner lining of this capillary, is going to be fenestrated endothelium. Fenestrated endothelium. We've seen this before. What are fenestrations? Yeah, these little holes right through the cell. Why did we spend so much time talking about fenestrated capillaries back when we were talking about capillaries? Because here it is. These are the fenestrated capillaries that we were talking about. We said, hey, they're found in the kidneys. This is them. These are the fenestrated capillaries that we're talking about. So they've got all of these holes in it. So that's going to allow lots of small things to go through very easily through all of those holes. But as we saw, those holes, those fenestrations, are not going to be large enough for our blood cells to be able to get out. So that's going to keep the red blood cells, the white blood cells, inside these capillaries. Then we've got the basal lamina, which is just a fancy way of saying the basement membrane. So that basement membrane, which is going to, of course, help to anchor these cells of the fenestrated endothelium, helps to prevent large proteins from being able to get across. Too many of those fibers that are in there, those large proteins, they're not going to be able to get out. So albumin stuck inside the capillaries. Great, that's where we want it. And then we want to be a little bit more selective even than that, because there are small and medium-sized proteins that could potentially be able to get out through those fenestrations, but we don't want them to. We want them to stay inside the bloodstream. We want small things like glucose, glasses, water. Those things can all get out, but we want smaller and medium-sized proteins to be prevented from getting out as well. And so now, in order to do that, we have to wrap these podocytes, these cells, around the outside of the capillary. And so these alien-looking cells cells. We'll see some more images of them in a minute. They look very, very alien-like. But they're wrapped around the outside of these glomerular capillaries. And they have all these little branches, as you can see, these branches that are sticking out in all different directions, so that we're going to have this kind of interlocking or interlacing branches. These podocytes have these little feet. They're called pedicles or pedicels, depending on how you want to pronounce them. And there's only a very, very small little slit in between each of these branches. Okay, so that's what's called a filtration slit. So the opening between the branches of these podocyte cells is called a filtration slit. So again, that's going to limit the size of substances that are able to pass through there. And not only that, it's not just an open filtration slit. There's actually a membrane in there as well. This is called the slit membrane. And so that's the one that's indicated by our pink layer here. And so this slit membrane, once again, will make it a little bit more challenging for those medium-sized proteins to get out, so that they're going to end up staying inside that capillary and not be filtered out as part of that filtration process. So if we take a look at how this looks in reality, so back to this image here, what is this showing us? Yes, the filtration membrane, but what is this showing us? The glomerulus and the capsule. So altogether, the glomerulus and the capsule is the renal corpuscle. So this is the renal corpuscle that we're seeing here. You can imagine that any fluid and small particles that are coming out of the glomerulus is then going to move into that capsular space and then be sent further along through that tubular component of the nephron. But here you can really see kind of the zigzag, all kind of scrunched up capillaries into this ball that forms the glomerulus, and then on that apical surface is where we find all of these podocytes. So if we zoom in a little bit closer, you see something that looks like this. And this is what I mean, it looks very alien-like. Right? So there's the cell body of that podocyte. Looks like some kind of Star Trek thing where it's attacking your face, right? But there it is. So there you can see the outline of the glomerulus, so this zigzag, or the capillary, I should say, the zigzag of the capillary right here, and then there's the cell body of the podocyte, and then all of these branches that are coming off of it. And they continue to branch and branch and branch and branch until you have all of these smallest branches that are forming kind of this interlocking network, that in between each one of those is where any filtration is going to happen. So these are all the filtration slits, all these little lines that you're seeing here. Those are all the filtration slits through which any substance that wants to get out of the glomerulus has to pass in order to get into the capsule. If we zoom in even closer, then you can see the structure here. So there's the cell body of the podocyte. These are all the pedicels, or these little feet that we were talking about, these branches, and then all of the individual little filtration slits. And that's through, that's where all of these substances would have to pass. And remember that there's a little membrane in there as well, that slit membrane.
Just to clarify, the morphology of these membranes is to literally, like, there's a layer by layer of how much to get through.
Exactly. So it's kind of a layer by layer approach to be able to say we're going to let less and less and less things through. So we're going to let some small and medium-sized things through that first layer, through those fenestrations, because those holes are relatively large, not large enough for blood cells to get through. Then we're going to have another layer. We're going to have that basement membrane that's going to prevent the proteins from being able to get through. Then we're going to have another layer that's going to prevent even smaller proteins from getting through. So again, we're getting more and more selective about the size of things that are able to get across, so that by the end, the only things that are able to get across from the lumen of this capillary all the way into that capsular space are going to be the smallest of those substances, like water and glucose and amino acids, the very, very small particles.
And those are also technically the weight that we're trying to get through.
And waste as well. So things like creatinine and urea and some things like hydrogen ions, these are all things that are going to end up being waste products that are all small enough to be able to move through this membrane as well.
So they're either being waste products or they're being absorbed.
Exactly. So that's what we mean by non-selective. So whatever's coming out here, as long as it's small enough, can be waste products or it can be useful things. And later on, in our next two steps, we're going to get back the useful things that we want to keep and then get rid of even more waste products into this filtrate. All right. So this is our really alien-like filtration membrane. Now we can look at the forces that are going to be driving this filtration. Oh my gosh. Look at all these words. But what do you notice about them? Lots of pressures, but what do you notice about these names? We just tweaked the name just a wee bit. So rather than talking about our capillary hydrostatic pressure, now we're talking about glomerular hydrostatic pressure. It's exactly the same thing as what we saw before. This is what's driving the movement of fluid and dissolved substances out of the glomerulus and into, not the interstitial space, but into the capsular space, right? Our capsular hydrostatic pressure, what was our equivalent of this before? Interstitial fluid hydrostatic pressure. So we said that there's going to be this space, or moving fluid into a different space. As fluid builds up in that space, there's going to be some pressure that starts to build up. We talk about it here as being this capsular hydrostatic pressure because now it's a little bit more contained. It's a little bit more of kind of an enclosed space as opposed to that interstitial space, which is quite a bit larger. So now we're going to see that this pressure might be a little bit higher than what we've seen before. And oh my gosh, this is exactly the same thing as what we saw before. Our blood osmotic pressure, or that blood colloid osmotic pressure, exactly the same thing. What generates this? Albumin, the protein that's in the blood that we made sure stayed in that bloodstream with all of those layers of that filtration membrane. So it's exactly the same thing as what we talked about before. And in fact, we dropped one of those pressures, and we're only going to focus on these three. So we're going to come back after the break, remind yourselves of what these pressures are all about, so that when we get into our post-break chats, you're going to go, yeah, I remember that. How does that pressure move in the other direction?